also have several fine speakers. There's a Prof. Diah Purnamasari, a well-known endocrinologist, and also Dr. Gaisani, pediatric endocrinologist, and also Dr. Sarah Firdausa, an endocrinologist from Aceh, and also Dr. Farid Kuryawan, a staff member of the endocrinology division from Jakarta. So this is part of the activity as the collaboration within the Indonesian's Medical Education and Research Institute from the Metabolic Cardiovascular and Aging and also the Indonesian Diabetes Associations. So the aim of this meeting is actually to share expertise and also perspective from different part of the world. So hopefully by these sessions, we can both learn from Prof. Erum Gafur, and then of course we would be more than happy to share our perspective. So the today's speaker will cover quite diverse, Prof. Erum. We would have Dr. Sarah Firdausa, is an endocrinologist uh, from Aceh, and also Dr. Farid will share some of the study on Ramadan from Indonesia, and then followed by Prof. Diah Purnamasari and also Dr. Gaisani. So I hope this discussion will not stop here after for the next 2 hours, and hopefully we can use this discussion as a new start for a collaboration, like you mentioned in our previous discussion, Prof. Erum Gafur, that we can hopefully we can have a joint project on diabetes or diabetes and Ramadan in the future. Now, without further ado, I would like to invite our chairman for the sessions, Dr. Roy Sibarani. Dr. Roy Sibarani is currently the president-elect of the Indonesian Diabetes Associations. He also the chief executive officer from the Diabetes Initiative Indonesia, and also a senior endocrinologist at the Indonesian Society of Endocrinology. He did his training from the Faculty of Medicine, University of Indonesia, and had several endocrinology courses at Harvard's Medical School. So without further ado, I would like to invite Dr. Roy to chair the sessions. Please, Dr. Roy.
Thank you. Thank you very much, Dr. Dicky. Thank you very much. And I'm very pleased to be here with you all, guys. This collaboration is really impactful for us to learn so many things. That's why. And also, I would like to say good afternoon to everybody, to our viewers everywhere, all around the world, in Pakistan especially. And I send you greeting. And I believe you will be here with your full attention because what we are going to present is such a very important thing. And this is seeing the in the next 2 weeks, we are going to have the Ramadan fasting, some very essential time for us to learn it more intensively. And without saying, waiting for another moment, I would love to invite our first speaker. Our first speaker will talk about diabetes and Ramadan, but it is in the different style of observation, which is CGM, continuous glucose monitoring, and Ramadan patient on basal and bolus insulin. This is such an interesting topic that we can go for sharing this. And believe me, we're gonna have a very tight discussion with this. So I would love to ask Dr. Farid. Dr. Farid is a MD, PhD from University of Indonesia, and now is a fellowship of endocrinology in University of Indonesia. In 2023, he got his PhD from Leiden University in the Netherlands, and now he is working in academic and medical staff division of endocrinology, metabolic and diabetes, University of Indonesia. So, Dr. Farid, we are waiting for your presentation now. Thank you. The time
Thank
is
you.
yours.
Thank you, Dr. Roy. Good afternoon, Dr. Roy. And good afternoon also, Prof. Erum Gafur, Dr. Diki, and everyone that attend this meeting. Today, like Dr. Roy already mentioned, I'm going to share a little bit about our project that we already performed in Jakarta and also in other part of Indonesia related with the observations of the glycemic control in patients with diabetes on maybe not directly or precisely basal bolus insulin. So I changed a little bit about my title. It's more on multiple daily dose insulin injection. Is it already in the
Very
slideshow
clear.
mode? A pilot study in Ramadan fasting in patients with diabetes that received multiple daily dose insulin injections actually did not significantly worsen their glycemic control or glycemic variability, and also did not increase their hypoglycemic episodes as observed using real-time continuous glucose monitoring system. Although important to note that we previously already observed that during this observation related with the percentage of subject achieving the recommended percentage of tiered time above range and time below range, although we did not observe statistical significance, we can observe some changes. So further study with a larger number of subjects or even in other high-risk profiles or high-risk populations is still highly needed in our populations. And later, one of the high-risk populations that are also going to perform Ramadan fasting will be explained by Dr. Sarah Firdausa related with the hepatic cirrhosis. So that's my presentations. I would like to thank for all of these people that I put down in this slide. So this is a collaboration of our hospital, Dr. Cipto Mangunkusumo Hospital, and with several endocrinologists around Indonesia in Malang, Makassar, Semarang, and also Medan. And also, most importantly, also thank you to all the study participants that underwent this study. Thank you. Sorry, Dr. Roy, I think you haven't mute your...
Yeah, now I'm on. Thank you. Dr. Farid has already make a presentation about how is the observation of people with oral medication on CGM, continuous glucose monitoring, one with IP Pro and iPro, then the second one with people with on Ramadan with with basal and mixed insulin, yeah, basal or bolus or basal bolus. I believe there will be a lot of questions around because I see now it's already been more than 100 attending this webinar. So we are very pleased to have your question, and please put your question on the chat on the question box. Yeah, we are going to make this discussion after every session already been presented. Now, our second presenter is Dr. Sarah Firdaus. Dr. Sarah Firdaus will present it about uh, how is the observational with the continuous glucose monitoring system with people on Ramadan fasting on sulfonylurea. Wow, it is such a beautiful observation because we know that everybody in Indonesia using sulfonylurea. That's very important if we know what exactly happened. Is there any glucose variability or is there any uh, hypoglycemic event? I believe that Dr. Sarah will present it very well, and I will present the curriculum vitae of Dr. Sarah. Dr. Sarah is a fellowship of endocrinology now in Medical University of Indonesia, and she was the master. She is the master of medical science in endocrinology from University of South Wales, United Kingdom. And I would love to ask Dr. Sarah to present your presentation. Thank you very much.
Thank you so much, Dr. Roy, and all the participants. As I'm living now in a remote area in Aceh, and due to technical meeting, my session will be shared as a recording presentation. which will be delivered by Miss Maya. Please help the delivery of this presentation, Miss Maya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor, Dr. Senior, and my colleagues. Thank you so much for joining this webinar today. I am Sarah Firdausa from Faculty of Medicine, Universitas Syah Kuala. Today, I would like to share about continuous glucose monitoring or CGM during Ramadan in patients using sulfonylurea. This topic is very important because sulfonylurea is still widely used in our daily practice, and many of our patients insist on fasting during Ramadan. And by looking at CGM data, we can see how glucose actually behave during Ramadan. As we know that sulfonylurea is still the most commonly used diabetes drug in many Muslim countries. However, it is also the main cause of hypoglycemia during fasting. And still, people insist to fast during Ramadan even when they are at a high risk. So in real life, patients will fast and our job is to make their fasting safer. It is well known that sulfonylurea will keep releasing insulin even when glucose is already going down, which is dangerous during fasting. And it becomes a concern because it increases the risk of hypoglycemia. And there are many studies which prove that sulfonylurea increase risk of hypoglycemia, such as APDR study, Daya Ramadan, Azza Ismail, it's to name a few, and many other similar studies also reported the similar finding. Let's step back for a moment to SMBG, self-monitoring blood glucose by using finger stick measurement. Most patients check their glucose level only 2 to 6 times a day. So SMBG shows only a few numbers, not the full picture. SMBG cannot show glucose trends and how fast glucose is rising or falling. So SMBG also does not monitor glucose during sleep, while most Ramadan hypoglycemia happen at night while patients are asleep. Another problem is that many hypoglycemia episodes have no symptoms, and this creates a blind spot in glucose management, which is especially dangerous in patients using sulfonylurea. Now let us see what CGM gives us. As you can see, CGM show much more than average glucose. You can see that there are CGM metrics which contain time in range, time below range, time above range, and other parameters. It also provides daily glucose pattern and daily profile of glucose across many days. This helps us to understand when problem happens, not just how high the number are. Here we can see two clear glucose spikes every day after sahur and iftar. And also, it may detect any hypoglycemia event, which is reported as TBR. Let's have a look at the first case I would like to share. This is Mrs. L, 60 years old with type 2 diabetes, liver cirrhosis, and hepatitis B. She is treated with glycodone and metformin. Her HbA1c is 7.5, which might look acceptable at the first glance. But when we examine her CGM data, we can see a very different story. There are two clear glucose spikes every day, one after sahur and one after iftar. And between this period, glucose levels are relatively stable. This tells us that the main contributor for hyperglycemia here is eating pattern and meal composition, not the fasting period itself. Now, this is particularly important because she is using an SU or sulfonylurea, which can stimulate insulin secretion independent of glucose level. So instead of intensifying therapy blindly, CGM can help us to focus on adjusting meal composition, redistributing carbohydrate intake, and optimizing the timing or dose of sulfonylurea during Ramadan. And this is a good example of how CGM can transform management from reactive to personalized. Now, let's move to the second case. This is Mr. GA, 54 years old with type 2 diabetes and liver cirrhosis and hepatitis B. She is treated with glimepiride and metformin. His HbA1c is quite high at 9.27, suggesting poor overall control. First, let's look at his CGM data before Ramadan when he was not fasting. We can see that most of the day is spent in hyperglycemia. His time in range is only 22%, and while almost 78% of the time is above the target. So outside Ramadan, his main problem is persistent hyperglycemia exposure. Now we look at what happened during Ramadan fasting. Interestingly, his glucose profile improved significantly, with time in range increased to more than 60% and mean glucose drops from 230 to 160. This is clearly show how fasting itself is not harmful for this patient. In fact, it can reduce hyperglycemia exposure, likely due to reduced meal frequency and caloric intake. However, CGM also revealed something important related to sulfonylurea. We start to see a trend toward glucose decrement before iftar, and this is consistent with the pharmacology effect of sulfonylurea, which continues stimulating insulin secretion during prolonged fasting hours. So while Ramadan improve hyperglycemia, sulfonylurea may increase the risk of late afternoon hypoglycemia. Without CGM, you would only see a better HbA1c and assume everything is safe. But CGM allow us to identify both benefits and risks at the same time. Now let's move to the last case. This is Mr. SY, 60 years old, with type 2 diabetes, liver cirrhosis, and hepatitis B. He is treated with liquidone, metformin, and sitagliptin. His HbA1c is 6.5, which suggests good glycemic control. When we look only at mean glucose level, they are quite similar before and during Ramadan, around 160. So based on HbA1c alone, we might assume that this patient is doing well. However, CGM tells a different story. Even before Ramadan, CGM detects episodes of glucose dipping into the low range, which were not captured by routine monitoring. And during Ramadan, these low glucose episodes becomes more apparent. This is particularly important in patients using SU. So, despite a good HbA1c and acceptable mean glucose, the patient is actually experiencing hidden hypoglycemia. And this case highlights that CGM is essential to uncover silent hypoglycemia, especially in patients treated with sulfonylurea during fasting. In our own study of diabetes patients with liver cirrhosis, we found a higher median glucose before Ramadan, and it becomes lower during Ramadan, but there was still a clear post-iftar glucose surge, and most glucose fluctuations came from high carbohydrate intake. Importantly, hypoglycemia did not significantly increase. And don't forget, we also need to see the raw trend in the CGM. The direction of glucose change is often more important than the number. For example, 90 milligram per deciliter is going down fast is more dangerous than 70 milligram per dl that is stable, and CGM can give early warning for the users. So don't forget also to encourage patients to break their fast if glucose goes below 70 or below 90 with downward arrows, or if glucose keeps falling, or if glucose is persistently above 30. The good news is that not all sulfonylurea have the same risk. Glibenclamide has the highest risk because long and severe hypoglycemia, while glimepiride is in the middle, and glyclazide, the modified release, has the lowest risk and is safer during fasting. While CGM helps us adjust treatment clearly, we can detect late hypoglycemia and reduce evening dose. We can see post-iftar spikes and focus on diet, and we can individualize therapy for each patient. As the take-home message, I would like to share that sulfonylurea is our high risk in Ramadan, and SMBG can miss nocturnal hypoglycemia, while CGM may reveal dangerous patterns. Trend arose in CGM might prevent emergencies, and CGM makes fasting safer. Thank you so much.
Thank you, Dr. Sarah. Thank you, Dr. Sarah. Dr. Sarah was showcasing the case of 3 patients on sulfonylurea medication. and put it in the continuous glucose monitoring. And this is very interesting because we see different case and a different report. And I believe that we will, you know, enjoy to make a question to Dr. Sarah with this presentation. And also don't forget for people who joined now, who attend this webinar to fill the attendance form. This has already been more 100 participation to join the room. Now, the next speaker will be talk about something very, very interesting and very, very useful. Because as I said that we are going to face Ramadan fasting less than 2 weeks. But the report from uh, next presentation is about diabetes Ramadan in the diabetes and Ramadan in Indonesia will be presented by Professor Diah Purnamasari, MD, PhD. She is now the professor of medicine from the Faculty of Medicine, University of Indonesia, and got her PhD in medical education in 2015. And now, uh, Professor Dia is the head of internal medicine specialist study program in the Faculty of in the medical faculty of medicine, University of Indonesia. With not further ado, Prof. Dia, I would love to see, and we love to see your presentation at the moment. Please, the time is yours.
Thank you, Dr. Roy. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon for all the speakers and participants. Due to the technical issue, maybe my presentation will be shown from a recording. Thank you for joining this session. Please, Dr. Aziza, you can share the presentation. Thank you. Thank you, Dr. Roy, for the nice introduction. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Thank you for joining this session today. My name is Diah Purnamasari, and I would like to talk about Ramadan fasting in Indonesia based on studies conducted in the Indonesian population. I will begin with the introduction, followed by the discussion on Ramadan fasting among Muslims with type 2 diabetes in Indonesia, and finally the impact of Ramadan fasting on health based on Indonesia data. Statistics show that Indonesia is the country with the largest Muslim population in the world, followed by Pakistan, India, Bangladesh, and Nigeria. By mid-2025, the population in Indonesia reached 284 million, and as many as 85% of them are Muslim. Indonesia is located on the equator, so the duration of day and night is relatively constant throughout the year, including the length of fasting. The average fasting duration is approximately 14 hours. Ramadan fasting is one of the 5 pillars of Islam, so it's obligatory for every healthy Muslim, as stated in Quran Surah Al-Baqarah, verse 183. During the fasting period, Muslims are prohibited from eating, drinking, including taking medication, and engaging in any activity that breaks the fast. Ramadan fasting is not the same as calorie restriction. Even though there are changes to the meal schedule, the total daily calorie intake remains the same. Ramadan fasting brings positive impact on healthy individuals, but may have negative impact on patients with chronic diseases. During Ramadan fasting, people tend to have a more regular schedule of eating, taking medication, and physical activity than before Ramadan. Apart from that, During Ramadan, Muslims are asked to be able to control their desires and increase their obedience to Allah Subhanahu wa Ta'ala, which may contribute to a better mental well-being. However, in patients with chronic disease, such as diabetic patients, there are insulin resistance and relative insulin deficiency cause hyperglycemia, triggering osmotic diuresis and leading to dehydration. In addition, receiving anti-diabetic therapy increases the risk of hypoglycemia among diabetic patients during Ramadan fasting. Therefore, diabetic patients who are at high risk are advised not to fast. However, if they choose to fast, regardless of the medical advice given to them, they should undergo pre-Ramadan assessment. Ramadan is a special month for Muslims. Food served at iftar generally more varied and tend to be higher in carbohydrate and fat. Some ethnic groups in Indonesia even have their own traditional Ramadan dishes that are high in carbohydrate and fat. During the Ramadan fasting, the main meal are typically divided into two, namely when eating at sahur and iftar. Calorie intake generally reduced in the first week, followed by the progressive increase over the remaining weeks. These are the glucose profile during Ramadan fasting in healthy and diabetic patients. A CGMS study during Ramadan reported stable blood glucose levels in healthy individuals without diabetes during fasting hours. At the time of breaking the fast, there were a slight increase in interstitial glucose and therefore blood glucose, but this increase remained within the normal range. The glucose peak at breaking the fast is greater in people with diabetes and is thought to represent a response to a carbohydrate-rich meal at breaking the fast, possibly amplified by hormonal changes during Ramadan. Patients taking insulin and sulfonylurea showing greater increases. During Ramadan fasting, diabetic patients face post-iftar hyperglycemia and pre-iftar hyperglycemia. Furthermore, several studies emphasize the higher risk of hypoglycemia among diabetic patients compared with healthy individuals during Ramadan fasting. This is the first study that I want to show. It is a prospective longitudinal cohort study that investigate glucose variability among subjects with type 2 diabetes during and after Ramadan fasting using CGMS in Indonesian population. It included diabetic patients who practiced Ramadan fasting for at least 14 days, subjects with history of CVD, CKD, severe liver disease, chronic GI disease, and autoimmune disease were excluded from the study. Body weight and body composition measurement were performed using a Tanitabia, and nutrient intake data were obtained using a non-consecutive 3-day food diary, where all subjects are asked to record their food and beverage consumption for 2 weekdays and 1 weekend day. Physical activity data were assessed using the Bochat questionnaire completed by the subject at home, and the questionnaire results were quantified to produce energy expenditure, which were expressed in metabolic equivalent. For glucose measurement, they use CGMS Medtronic iPro2, which measure interstitial glucose level with a minimum observation of 3 days. Roche AcuCheck Performa glucometer was used to calibrate CGMS data from interstitial glucose with capillary glucose measurement performed twice daily before suhoor during Ramadan or in the morning before the first meal post-Ramadan and before bedtime during both periods. They were also instructed to do SMBG if they experience hypoglycemia or hyperglycemia symptoms. This is the baseline characteristic of 10 participants. The average of HbA1c is 8.8%. All subjects were taking metformin, with 4 receiving metformin alone and 6 receiving a combination of metformin and another oral antidiabetic drug, and 5 subjects received a combination of metformin and sulfonylurea, while 1 received metformin, sulfonylurea, and alpha-glucosidase inhibitor. As the primary outcome of the study, MAGE values were similar with the fasting and non-fasting periods. Consistent with this, mean interstitial glucose, maximum interstitial glucose, minimum interstitial glucose, and hypoglycemia rates didn't differ significantly between the two periods. Interestingly, the percentage of interstitial glucose within the target range appeared higher during Ramadan compared to the post-Ramadan period, but did not reach statistical significance. Furthermore, the percentage of interstitial glucose values above the target range was relatively high, especially in the non-fasting period. No episodes of hyperglycemia or symptomatic hypoglycemia were reported. This illustrates the fluctuation of interstitial glucose during Ramadan compared to non-fasting periods. During Ramadan, interstitial glucose peaks at 6 a.m., while after Ramadan, it peaks at 12 p.m. During Ramadan, interstitial glucose reached its lowest point at 6 p.m. just before breaking the fast, while after Ramadan, its lowest point at 6 a.m. When comparing nutrient intake during sahur and iftar, there is a trend towards high total energy and carbohydrate intake during iftar. Physical activity profiles during the fasting and non-fasting periods were comparable. These are the summaries of the study. The overall glucose variability in subjects with type 2 diabetes who fast during Ramadan did not differ during and after Ramadan. It is also important to note that the pre-iftar period is a period with the high risk of hypoglycemia. Thus, it is advisable for subjects with type 2 diabetes to perform frequent blood glucose checking during that period. Furthermore, with a notable surge of glucose and after iftar, adjustment in terms of dietary intake and medication dosage should be recommended. Another study was conducted by Dr. Hendra Sufri in Aceh, Indonesia, which included adult diabetic patients. The aim of the study was to examine the food consumption profile during Ramadan, as well as dietary knowledge and attitudes among Muslims with type 2 diabetes. The questionnaire asks patients to recall the frequency of their consumption of food from various food groups, including whole grain foods, vegetables, fruits, fried foods, and higher sugar desserts during the previous Ramadan. This table presents the characteristic of the 401 participants. 54% were female, the mean age was 57 years, almost half of them had hypertension, and the majority of subjects had diabetes for less than 10 years. In this study population, 72.6% completed the full month of fasting. Among them, more than half had received educational information about diabetes management before Ramadan and had consulted a healthcare professional before Ramadan and had received information Ramadan specific diabetes education from their healthcare team. After adjusting for confounding factors, logistic regression analysis found that patients' dietary behavior during Ramadan were associated with specific dietary knowledge and food preference. In general, Patient dietary knowledge was good, except for knowledge of whole grain foods as a source of fiber and butter as a source of saturated fat. The participants were aware that low GI foods were healthier than high GI food, and this knowledge was positively correlated with consuming high fiber foods 3 or more times per day. Lower preference of deep fried food was statistically significant associated with lower consumption of this food. Despite awareness of the adverse effect of added sugar on uncontrolled blood glucose level, many participants continue to consume high sugar dessert during Ramadan. The perceived availability of whole grain foods was associated with consuming whole grains at least once. The perceived availability of fried food at home was positively correlated with the frequency of fried food consumption in patients. The summary of the study are: there is a room for improvement in the whole grain consumption among Muslims with type 2 diabetes during Ramadan. In addition to knowledge and preference, the food environment that provided whole grain and deep fried food will be important intervention target for improving healthy food consumption. The pre-Ramadan educational program should focus not only on improving patients' knowledge and attitudes, but also addressing environmental barriers in order to effectively help patients achieve dietary recommendation more effectively during Ramadan. Finally, this brings us to the conclusion. The first one, the overall glucose variability in subjects with type 2 diabetes who fast during Ramadan didn't differ during and after Ramadan. Second, blood glucose monitoring during pre and post-iftar period is advisable to monitor the risk of hypoglycemia and control the surge of glucose level during that period. Dietary behavior during Ramadan were associated with specific dietary knowledge and food preferences. The pre-Ramadan educational programs should focus not only on improving patients' knowledge and attitudes, but also addressing environmental barriers in order to effectively help patients achieve dietary recommendations more effectively during Ramadan. I think this is the end of my presentation. Thank you very much for your attention. Thank you.
Wow, thank you very much, Prof. Dia. Prof. Dia is reporting about condition and a situation of the Ramadan fasting in the most populous Muslim country in the world. So I believe that we will have a lot of questions for to Professor Dia, and we are waiting your question through the chat box. Now we are coming to the second. But I don't think it's second. Yeah, 1, 2, 3, 4. The fourth presenter. It will be Dr. Gaisani Fadiana. Dr. Gaisani Fadiana is now a pediatric endocrinologist lecturer in Faculty of Medicine, University of Indonesia. So now we are crossover to pediatric problems. Yeah, right. Dr. Gaziani will talk about Ramadan in the school, please. So the time is yours, Dr. Nina. Yeah, time is yours, and please make your presentation. Thank you.
Thank you, Dr. Roy. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. So it is a great pleasure for me to join my colleagues, my seniors also here. And thank you very much for the committee for giving me a chance to discuss and talk about diabetes and Ramadan, particularly from a pediatric perspective. Okay, so let me share my slide. Okay. Okay, so talking about diabetes, particularly in children and adolescents, we know that this has become one of the global health challenge because the incidence is increasing, and also those who are living with diabetes, particularly type 1 diabetes, and also type 2 diabetes with youth onset are all at risk for early complications, comorbidities, and also mortality. So if we talk about later about Ramadan and also about fasting, we should consider about this risk because early complications such as TKA and also hypoglycemia are actually quite prevalent in children and adolescents with diabetes. So if we talk about diabetes in children and adolescents, I might be put my focus more on type 1 diabetes because it accounts for the majority of diabetes types in childhood and adolescence. So these are maybe some of the questions that we might have in our head, not only us as healthcare professionals, but also families, parents, teachers, and also overall society. So these are maybe the most important questions that we have to answer. The first one is, I think this is the basic question. Are adolescents with diabetes allowed to fast? If they are, how to do it safely during Ramadan? And is there any specific recommendation for meal plan and insulin dose adjustment, or also when to break the fast? I think these are the important questions that we might want to answer this time. So we begin with one of the basic question: are adolescents with diabetes allowed to fast? Unfortunately, there are actually no specific guidelines that state these adolescents can fast or not, or there's no guidelines that specifically say the cutoff for the age. But we do have some of the guidelines, especially from ISPA, the International Society for Pediatric and Adolescent Diabetes in 2022. So most of the talk today that I will be taking it from these two guidelines, the management of diabetes in school and also during Ramadan fasting. So the first thing that we usually do, especially in education session for the parents, we teach them to identify the risk first by answering these three major aspects that they have to answer. The first one is there any previous fasting experience? Is this the first time for them, for the children and adolescents doing fasting, or is there any previous fasting experience? But if we talk about children, adolescents, they are actually in dynamic phase because they are still growing, they are still developing, the weight is increasing, the height is also developing. There are many challenges with the metabolic system, for example, during puberty. And then there are many variation about school activities and school performance, maybe mental health situation. And it becomes a really great challenge for us to adjust the diabetes management in daily life, particularly at school. But it's really important for us to understand about the previous fasting experience. For example, is there any hypoglycemic events? Is there any hyperglycemic events maybe lead to DKA, for example? And we also want to know about the recent glycemic control. We usually ask for the most recent A1C, for example, in the past 3 months, or even we usually do the A1C around 2 weeks before Ramadan fasting to give us the base where we can start, especially for the insulin dose adjustment. And we also let them reflect also, is there any history of illness? Is there any history of DKA for the past 3 months, for example? And we ask them and also collaborate with the pediatricians to assess the current overall health condition. So there is a risk group stratification for fasting in type 1 diabetes, but it's not specifically for children and adolescents, but I think we can implement it, some of them. So we usually ask the parents if there's any history of severe hypoglycemia, which may be leading to hospital admission within the 3 months prior to Ramadan, or is there any severe hypoglycemia or A1C more than 10%? Or is there any recurrent hypoglycemia or even hypoglycemia unawareness, which is really important because sometimes young children or young adolescents still don't have the ability to communicate the symptoms of hypoglycemia, for example. And is there any history of DKA or acute illness within the 3 months prior to Ramadan? So if there is one of these risks, we actually tell the parents that this is very high risk, and we generally don't recommend them who have this history of these conditions to not fast during the Ramadan. So basically, if we talk about type 1 diabetes, it is considered to be a very high-risk group. So we, in pre-Ramadan education session, we usually emphasize this to the parents and families that having type 1 diabetes is already a high-risk situation. But if we tell them not to fast, sometimes they still want to fast. So these are actually the challenge. So we basically tell them that whenever or whatever they want to do or adjust the insulin or also the meal plan, they have to be taken under the close supervision by the expert, which is pediatric endocrinologist or any pediatric diabetes team. And we say that they might do the fasting during Ramadan if they have good metabolic control, if they are able to regularly monitor the blood glucose, and with a specific condition under the close supervision of diabetes team and no history of severe illness or DKA. So the next question, if they are allowed to fast, how to fast safely during Ramadan? This is also the most important questions for us. So the general rules is we have to start with the pre-fasting assessment and pre-fasting education because this will give the good basic or good foundation before starting Ramadan fasting, and also the period of fasting and also monitoring after the fasting month. So the thing that we usually recommend is to optimize the glycemic control before the fasting. So let's say we do have another like 1 month of Ramadan fasting. We usually want to check how about the glycemic control. If there's any adjustment of insulin that we can do prior to Ramadan fasting, that would be more beneficial. And the next one, we usually organize the pre-fasting counseling and diabetes education individually or for groups. We usually have like workshop for Ramadan preparedness workshop, and also counseling individually during visit before Ramadan month. And we have to make sure that they will be aware of hypoglycemia, risk of hypoglycemia that should be excluded before the fasting period and should be monitored during fasting. And these are also the recommendations that have to be part of the diabetes management during Ramadan. The first one is about the insulin adjustment and how about the glucose monitoring, how about the meal plan, physical activity, sick days, and hypoglycemia, and also recognition and management of hypoglycemia that might happen or occur during Ramadan fasting. So these are one of the general recommendation. Of course, it's not going to be a same per individual, but this is more like individual case, but this is general rules that we usually start with. So with the basal insulin, we have to check with the glycemic control, the recent one. So that's why usually before Ramadan fasting, we try to check for the A1C at maybe 2 weeks or 3 weeks before Ramadan fasting, just to know where we want to start the basal insulin. If the children, adolescents with good glycemic control, and we also recognize that they're probably a high risk of hypoglycemia, we tend to reduce the dose. But if he or she has poor glycemic control or more than 8% who wish to fast, we generally keep the same dose and we follow up with the close glucose monitoring just to adjust the dose to make sure that there are no hypoglycemia or hyperglycemia. And how about the bolus or prandial insulin? It's usually based on how we give the insulin dose. Is it based on carbohydrate counting or is it a fixed dose? If it's carbohydrate counting, so we can continue the same carb ratio for iftar and suhoor dose. But for fixed dose, we generally recommend them to reduce the dose by 20 or 30%. And in terms of glucose monitoring, I think this is very essential. This is very important because, again, the risk of hypoglycemia is very important to be aware of. So we just want to make sure that the checking glucose does not break the fast. So this is one of the important information for the parents and also for the children, that please check the blood glucose regularly. And we usually add more times to check for the blood glucose, for example, in the midday and also mid-afternoon, because those are the times that have the higher risk of hypoglycemia. And immediate action is required for both low or high readings. So, for example, to break the fast, so they have to know when is actually the cutoff of hypoglycemia and hyperglycemia to break the fast. And regarding nutritional management, it's basically the same with other than Ramadan, but we try to make sure that they will consume the suhoor as late as possible, and also to consider the quality and quantity to be still healthy food, a balanced diet based on the recommended dietary allowance. So physical activities is also important to consider because the children and adults are usually still active during Ramadan, and this is something that we have to monitor. Like, for example, if they are at school, maybe during the break time, they usually running around. So that's something physically challenging. This is something that we have to consider for the risk of hypoglycemia. So the important thing that we have to tell the parents and also the children and adolescents is when to break the fast. So the first one, if the blood glucose rapidly falling or below 70 milligram per deciliter, or if any blood glucose more than 300, or if there's any symptoms of hypoglycemia or illness. And again, sometimes, the challenge with children and adolescents, because if, for example, hypoglycemia occurs 1 hour before dawn, like they have to maybe they want to continue the fasting, but actually want to tell them that this is very important, like to break the fast. And the children and adolescents can be a bit competitive regarding, something that just learn, like fasting. They tend to want to fast fully, like in a month. And this is something that we have to tell, because the priority for the parents and the families is to do the fasting safely. And how about the school? Actually, school is a high risk environment, because if, let's say, we have 14 hours of fasting, I mean, like more than 50% will be spent at school. And there are also physical activity during the break time, and there's also limited supervision compared to home. And of course, again, peer pressure, something that might be quite like a drive for children, adolescents to keep the fasting, even though probably they have hypoglycemia or hypoglycemia symptoms. And so these may be the important roles of teachers and school staff and also the peers that they have to be aware of diabetes and Ramadan-related risks, like symptoms of hypo and hyperglycemia, and to allow children and adolescents to have the glucose testing and also breaking the fast whenever needed, whenever they are like hyperglycemia or hypoglycemia. And also the close communication with the parents, maybe also with the pediatrician, is very important. And how about the roles of peers is actually regarding the stigma around the eating and drinking, especially during fasting hour. Like sometimes they have a pressure to continue the fasting, even though they have hypoglycemia, when at that time they should break the fast. So this is very important for peers, teachers, and school staff to promote a supportive and inclusive environment. So that's why we need to have individualized school diabetes plan. It is a clear shared plan between school staff, the parents, and also maybe doctors or pediatricians, like regarding when to check the blood glucose, allowing them to check the blood glucose regularly at the certain times, and also breaking the fast when needed. And of course, the emergency contact with parents and also pediatricians are really important. So back to the five management pillars of diabetes in children and adolescents, basically we have to let the children adolescents understand and be able to do such of skills like for example insulin management, how to adjust the insulin doses during Ramadan and also in school, and give dietary management, how about the meal plan, and also physical activities, when to do the blood glucose checks, and how to do the monitoring at home and also in school. Have to be very careful if we have children, adolescents with diabetes who want to fast. And we usually do individualized assessment and also education prior to Ramadan fasting. And we have to make sure about the safety aspect. Safety is the goal. So, and education and monitoring are also critical. And of course, we need a collaboration between healthcare professionals, families, and also school teachers and staff. So I suggest also, if you are interested in reading more about diabetes in children and adolescents, particularly in Ramadan fasting, you can go to ISPAD and look for the clinical practice consensus guidelines. I think these are the last slides. So thank you very much for the time. Back to you, Dr. Roy.
Thank you, Dr. Kaisani. As a pediatrician, you have presented about your thought um, for the for the adolescents or the children when they have to do fasting, and what is the consequences, and also what we need to know and we need to talk about with this kind of situation. This is such a very interesting topic, and I think we will have a lot of questions from all the audiences, and we are waiting for that through the chat box. Now, we come to the uh, part of a very important thing. We come to the keynote speaker. Keynote speaker will be talking about diabetes and Ramadan guidelines. And the one and only who will present this topic is now sitting down very careful, very quietly in Karachi, Pakistan, and she will talk about the guidelines in for Ramadan, and there is no other than Miss Erum Gavur. Ms. Erum Gavur is a Master of International Public Health from the University of Liverpool, United Kingdom, and also certified diabetes educator from the Missioner Institute, Canada. And in 2010, she has this diabetes educator in Bakai Medical University, Pakistan. Now, Ms. Arum Gafur is a vice president healthcare professional in International Diabetes Federation. And also, she is now the president of National Association of Diabetes Educators in Pakistan, and also the project manager changing diabetes in children in Pakistan. And yeah, of course, she is teaching faculty member in Just Hospital and Health Network Pakistan. We are I really want to talk with you, directly, Miss Gabur, but now we just have our time online. But we believe that we will have a lot of insight from you with your experience and with your position. Now, I will let you talk and presenting about your thought in diabetes, the guidelines for Ramadan. Please, thank you.
Thank you, Dr. Rai, and Assalamu alaikum all. So, as you guys know, that I'm really impressed with the previous speakers. They have done a wonderful job, and definitely I'm not going to share something different. They are very experienced people, but maybe I can add few things in that. So today I'm going to speak about the prevalence, the diabetes guidelines, and this is something that more than right now, if we see the statistics, there are more than 150 million Muslims across the world with diabetes. And most and in them there is 160 million may choose to fast. So this is a big number, and that is the reason that we need guidelines for diabetes self-management, and even for all the management of diabetes when actually they want to fast despite of the type of diabetes. uh, there are multiple factors which influence the diabetes fasting, and sometimes it make tricky. So, as Dr. The last speaker said, the type 1 diabetes that is very controversial in many schools of thought, that people or the children with type 1 diabetes shouldn't fast. And there are many school of thoughts, and I'm included in them, that they should fast. So the type of diabetes and the level of their glycemic control, the medication they are using right now, because sometimes people are presenting with different comorbids. So this is also the medication used and the comorbids come together, and the personal circumstances. And even then, there are more, if we go in the details, that if someone is having DK in last 3 months, or the repeated episodes of hypoglycemia. So we need to know all these factors, not as being a healthcare professional, but we have to discuss all these with our patients as well. So the question is that, is it safe to fast for people with diabetes or not? Because as I said, that actually this is, I usually say when I do counseling about the fasting during Ramadan, or maybe sometimes not only in the Ramadan, other religious where people come to me with from other religions, and I always says, this is not the religion which is saying to you that fast and die. So we have to adjust, and we have to understand then actually what is best for us. There are many studies out there, and I'm sure you guys have known that fasting has positive effect on people with diabetes, especially type 2 diabetes. And they even emphasized on patient education, because the patient education make all the role very clear. And definitely you and me or any doctor or HCP doesn't remain with people with diabetes or our patient 24/7. So they have to be, I would say, empowered. So there are evidences that it would be beneficial if the fasting would be planned and pre-assessed. So there are many proven impacts of pre-Ramzan education, because I must say that pre-Ramzan education and pre-Ramzan assessment is very important. I am the author of New Guidelines, DAR Guidelines, one of the author, And we have a very big section for pre-Ramzan assessment and pre-Ramzan education. So, what impact we can get if we give the pre-Ramzan education? That if most of the time with people with type 2 diabetes presenting with a lot of weight and excessive weight, and this is the high time and the best time when you can take double advantage, you can lose weight and even with the sawaba as well. So, weight loss and the reduction in the risk of hypoglycemia, because when they take the proper education, they will not have any hypoglycemic episodes and reduce the incident of hypoglycemia and improve glycemic control. The most alarming situation with the patients who came up in the very early of the Ramadan, we expect at hospital that most people come and who didn't took the education, and we get ready for that. So the incidence of hypoglycemia is common, and if they can take pre-Ramzan education, then that get reduced, and the severe episodes of hospitalization can be reduced with pre-Ramzan education, and improve glycemic control with notable change of biochemical and biometrical measures in high risk individuals. Similarly, we also, if we also provide the Ramzan education, then the patient are more likely to improve their perception about it, because I'm not sure about Indonesia, but in Pakistan, many people thinks, and even in some other countries, that the people with diabetes shouldn't fast, or so when they experience it with care, with proper monitoring, with proper assessment, then their perception also get improved, and they get better HbA1c and weight reduction. So what are the main components of pre-Ramzan assessment? First of all, we always teach our patients, always request them that come and visit us like 6 to 8 weeks before Ramadan. And because in that way, we will be able to get all the tests, all the biochemical markers, and their preferences as well. So, what actually pre-Ramzan assessment plan, that we need to take the detailed medical history, that either they are presenting with any critical situation, or we are expecting any mishap if they will fast, and aspects of diabetes, ability to self-management, either they will be able to manage their condition during fasting or not, and presence of comorbidity, and also we also see that if they are actually really want to fast, or they are in pressure, because sometimes, as Dr. The last speaker said, sometimes it is societal, it is familial pressure as well. The individual prior experience in managing diabetes during Ramzan fasting, and individual ability to manage their diabetes, and either they will have further risk or not. So these all are the parameters which should be addressed, and their dose should be adjusted, their insulin should be adjusted. If they are on OHAs, then they have to be adjusted, and some of the OHAs, oral hypoglycemic, may get changed as well. So these are, and it should be done prior to 6 to 8 weeks. So most of the time we think that we need to provide education to the people with diabetes who wish to fast, but this is not the way. Actually, we need to target the healthcare professionals as well as people with diabetes and the general public, or I would say the family and the community. They should also know that actually how to fast during Ramadan. with diabetes. And what are the key components which we need to consider um, for Ramadan fasting education? That is risk quantification and assumptions and removing misconceptions. Blood glucose monitoring, how it should be done, when it should be done, and when we need to contact our healthcare professional immediately or reach to ER. And fluid and dietary advice, when to how much fluid. People usually don't take fluids during the Ramadan, and dehydration is one of the common complication during fasting. So physical activity and the exercise advice, medication adjustment, and testing fast. When we invite them and they reach to us prior to 6 to 8 week, we always have room to make a test fasting, so they will not actually have any adverse event actual at the time of fasting. And as Dr. Ganes discussed, that when to break the fast and recognition of hypo and hyperglycemia symptoms. Sometimes people who have a very good control or using beta blockers, they don't get the symptoms. So we specifically educate them that they have to check their blood sugars more often than other people with diabetes. And the risk quantification, this is from last Ramzan DAR guidelines, and Dr. Fareed has also discussed that. So I'm just quickly uh, just going through with that. That we have scores, and he have explained this as well. But this time we are coming up in next, hopefully next 2 months, that you will get new Gadar guidelines, and in that you will see that we have even included the LADA as well. So this is the risk stratification as detailedly discussed by Dr. Fareed. So monitoring. So this is something which is very, very important, and we need to teach first thing our patients that while monitoring our fast didn't damage or didn't get break, yes, ablution get broke, and ablution is not that kind of thing which damage the your fasting. Ablution get break, and you can do that again, the wuzu. So it has to be very clear to our people with diabetes. And the other thing, that what are the suggested times, that pre-dawn meals monitoring, midday, mid-afternoon, pre-sunset meals, 2 hours after iftar, and at any time when there's symptoms of hypoglycemia or hyperglycemia occurs. But practically, I must say that most of the people doesn't check their sugars for 7 times. So what I would do, and what we suggest, that we ask them to check 3 times in a day, and next day 3 times the other times. So we can actually we can actually have the report that what is happening and how they are doing. So this is the practical way, but the recommendation from the DAR is the 7 time profile which you are seeing right now. Fluid and dietary advice, uh, that was also discussed by our previous speaker, but I want to add some points, that there are 10 principles of Ramazan nutrition plan according to the DAR, and which I must say include the things which has not been discussed, that we should avoid sugary heavy desserts, because many people, I would say, go for the feast at the iftar. So we should advise them that they should avoid the sugary heavy desserts, and take the low GI and high fiber carbohydrate and take iftar as late as possible. We usually ask them to take iftar just before 20 minutes of Fajr, and also struck them because throughout the year we tell them that avoid fats and take as less as fat as can. But in Ramadan, we recommend them that at time of sahur, take adequate portion of protein and fat so that can induce satiety. And most of the time that give cover for 8 hours. So the risk of hypoglycemia get reduced. Now, this is also discussed that when to break the fast. And I am totally agreed and totally aligned with our previous speaker that people don't want to break their fast. And I'm so sorry. And the main thing is that we recommend them that if your sugar's getting less than 70 milligram per deciliter at any time of the day or more than 300 milligram per deciliter, then you should break the fast. This is the guideline. But practically, we always ask them if they are hyperglycemia, then we ask them that check your sugars again after a while. And if there is very less time in iftar, so we ask them like 30 minutes or 20 minutes. And so we ask them just lay down and because most of the time people don't want to break their fast. So this is the practical thing, but the guidelines are in front of you. Medication adjustments. Medications adjustments are very tricky during the Ramadan. Dr. Fareed and some of our eminent speakers has discussed this. So I'm just going to give a brief that if the patient is on monotherapy and they are using oral hypoglycemic agents, then and if they are using metformin, then it should be full dose shifted from morning to iftar and evening dose to sahur. And if they are using a carbos, then the that it should be moved to iftar and evening dose should be at sahur. And if that is DTP4 inhibitors, that it would be moved to iftar. And if they are using TZDs, then it should be moved to iftar time. And if that is SGLT2 inhibitors, then it would be moved to iftar time, not at the sahur. Similarly, excuse me, I don't know what happened. Sorry, I think that is something
Yes.
internet.
Okay.
Okay, wait a minute.
Everything is okay?
Yeah,
Mr. Fu?
yeah. Well, actually, I think internet is getting, yeah.
Okay. But it still work, yeah?
Is it okay now? Can you see my screen?
Yes, yes, I can see
Yeah.
clearly your screen.
So,
Yeah.
Dr. Fareed has discussed the sulfonylureas, the use of sulfonylureas. So, if the dose is OD, so it should be shift to iftar with reduction of 25%. And if the dose is BD, and so it should be moved to morning, should be moved to iftar with reduction of 25%. And evening dose should be half at the time of sahur. So we have some patients who are taking combination with the metformin and sulfonylureas, and I'm going to show you that how to adjust as well. So patients who are taking insulin and they are using long acting because most of the time we recommend our patients that they should be taking long acting insulin. So basal insulin should be reduced to 30%, and if they are taking sulfonylureas and insulin as well, so we recommend that the sulfonylureas should be reduced to 75%, and those should be according to their uh, glycemia, the level of glycemia intake, and the readings during fasting. And how can we adjust the premix insulins? I'm not going to take the trade names. That is, if that is BD, then we go and reduce the BD dose to at iftar, at iftar to 75% we give them, and at evening evening dose should be at sahur, and that should be reduced to 50%. But with all this, I must say that we normally don't recommend pre-mix insulin during Ramadan. We want them to come on free mixing rather than pre-mixing. And if the patient is on R and insulin, or I would say the premix free mix insulin, then if patient is taking BD dose, then we reduce the morning dose, shifted to aftar with a reduction of 25% in basal insulin, and the dose, evening dose should be half, and they have to give it at sahur. Uh, Similarly, we need to understand that actually the targets should be achieved, and what are the best targets. So during Ramadan, the best targets are 100 to 200. And normally, how we explain that to our clients, to our patients, that you should have less control during the fasting time and the tight control during the non-fasting hours. So that's how, if their sugars remain between 100 to 200 between the fasting hour after sahur till iftar, then they will not have the risk of hypoglycemia. And after iftar to sahur, they will have, I usually give the targets of 160. And I ask them that that's how you will control your diabetes, and overall your HbA1c and the glycemia will be improved. Physical activity. The beautiful lady before me has explained the physical activity in respect of type 1 diabetes, but actually the physical activity is same for everyone, and it always give a good impact on the glycemia, either that is type 1 or type 2. We always recommend that people should do physical activity after iftar, after 2 hours of iftar. And also, I would like to add that here, that if someone is offering Taraweeh, then it is equal to 30 minutes of physical activity. So if the patient is coming and they are willing and they are intending to offer the Taraweeh namazes, that you can explain and share the knowledge, that that would be equal to the physical activity, and it would be more good for their better control. So the education is essential component for successful diabetes management. And this is not only for the people with diabetes, it is also for the physician. So these are the 5 components of our patient education. The first, the risk system is stratification, and the second is glucose monitoring. And we should understand that it does not invalid fasting. As we discussed, it only invalid the ablution. And can we should be very firm that when to break fast, at what reading we need to take very seriously and contact our doctor immediately, and reading need immediate actions. medication alteration, nutrition. Nutrition, we need to see that we have to fast. We shouldn't go for the feast. And exercise also is very important to achieve good glycemic control, either that is Ramadan or not. So, in summary, I would say a pre Ramzan assessment is crucial, and pre Ramzan education is the key component and must understand when to break the fast. And we have to understand and we have to learn this because this is a very important point. And medication dose adjustment is also mandatory. And in the last, I must say that you guys also teach your patients that your doctor is equal to a senior religious scholar for people with diabetes who wish to fast during Ramadan. If doctor is saying that there is risk, if doctor is guiding you, you must listen to them, and you must consider them as a senior religious scholar. So thank you so much.
Thank you, Ms. Gafur. It was such a inspiring lecture, and it is time for us to do some question and answer time. And I know there will be still a lot of things to be asked from our audiences. But firstly, there is a question for Dr. Farid, the first speaker, talking about uh, the Ramadan is not associated with a variability of doing oral anti-diabetic, and also in people with insulin. The question is, do you think that we need to expand the population to be more to get the real picture of this, this situation through Ramadan? Please, Dr. Farid.
Yeah, thank you, Dr. Roy, for the questions. Also, is this the question from the participants or from the attendee?
Yeah. Mhm.
Yeah, yes, I do really agree with the questions that since the previous study that I show is only very few patients, like the oral anti-diabetes is only 8, and also the multiple daily dose insulin injection is only 29. So it would be really great if we can expand it into more like more diverse populations, like with a larger number of subjects and also across Indonesia, not only the big cities, because I think for the first study, like the oral anti-diabetes is only in Jakarta. We In the second study, we already include several subjects from big cities across Indonesia. So it would be great to have those kind of study, although one of the uh, I think obstacles, not obstacles, but the opportunity now we have to find the funding itself to like gather all of those. Maybe if we can get more than 200 subjects or even 500 subjects, that would be great.
Well, this is a very good time for us to make collaboration with Pakistani. I know there will be a lot of subject throughout the country to be participated in this study. Is that right? And then we can ask International Diabetes Federation probably to get some, you know, something to sponsor the study. Yeah, we think that this is very good because Pakistani and Indonesia, the large population of the Muslim who doing Ramadan. I don't know. What is your comment, Ms. Gafur?
Yes, and definitely, actually, unfortunately, IDF doesn't fund things, but we have many other opportunities who
Wow.
can fund these activities and other bodies. And the best thing is that we can come up something for the regional, because that would help not only us but also help the other expert to come up, and we can come up with some new, I would say, I actually don't like the word guidelines, because this is not, I would say, the practical aspects. So yes, an IDF will also can participate and give expertise and generate links, and I'm sure the funding is not a very big problem, because when you do some regional things, then I'm witnessing many bodies, in fact the University of Harvard and such
Mhm.
kind of institutes do well.
We'll be waiting, Mr. Rum. Yeah, don't lose from us, yeah, because we're gonna catch you. We need more.
Yeah, yeah, don't worry, I'm with you.
Okay, thank you. The second question I got, it is for our second presenter. The question is, do you think that is a very important for this for your report about the using of the glyquidone and the glimepiride, or is there any specification that is very safe for sulfonylurea to get it in the Ramadan fasting month? Please, Dr. Sarah.
Okay, thank you so much for the question. Is it quite clear, my voice? Here is very heavy rain in Malta. Is it clear, my sound?
Mm.
Can you hear my...
We cannot hear you very clear.
Okay, here is the
Yeah, that's
rain is
better.
so heavy. Okay, okay, so
I will
here,
help
here.
you.
Okay. Okay, so for that question, thank you for the question. Yeah, not all the sulfonylurea has the same risk, and if we have the chance to choose, so we better to choose modified release glyphosate, because it can release the substance very slowly, and also it can be safer for patients who observe fasting during Ramadan. While glyphosate or glyphosate even it has a long, it has a shorter duration of action, but in terms of saving, in terms of fasting, I think glyphosate modified release is a safer for us.
Okay, good to know that. Yeah. And then there is some also several questions handed to Professor Dia from Husnul Mardianawati. Yeah, from Husnul Kardiawati. Hello, Husnul. Husnul asking about, she's a clinical nurse working in the government ministry clinic. And the question is, what is the most effective and clear way to provide patient education on meal planning and medication adherence for individual with diabetes in clinical setting?
Okay.
Please,
Thank you,
Dr.
Dr. Roy. Yes, thank
Yeah.
you, Dr. Roy. Thank you, Miss Kusno. Actually, this is the expert of Dr. Roy about education, but I will try to answer the questions. First, maybe we must optimize the knowledge and attitudes of healthcare worker and educators, because according to study by Sukiharto in Surabaya, Indonesia,
Yeah.
he found that healthcare workers' knowledge about diabetes self-management during Ramadan is very low. So the first is about the knowledge of the healthcare workers or educators. The second one, I think there must be a good collaboration and trust between the patient and the healthcare workers. Both must share the same goal and the same desire to achieve them. Sometimes doctors do not have enough time to build a bond with the patient, so not all of the patient's condition can be fully understood by the physician. And the third, I think we need to involve the family, because it's very important for patient to get the support from the family while maintaining their compliance. The family also plays a role in providing food, reminding the patient to take the medicine, and then accompany the patient when go to doctor for checkup and etc. But um, however, we know that maintaining a healthy lifestyle is not easy, especially for a patient with chronic disease who are prone to feeling bored or depressed and even easily get acute complication from the disease they suffer from. So maybe that's my opinion about that, Dr. Roy.
Yeah, wow, so inspiring. Thank you, Prof. Dia. And you must know it also better, Ms. Gafur. Can you just make some, some experience of you during your work as an educator also in Pakistan? Is it the same like here in Indonesia?
Yes, I am very much actually amazed that it is. I feel like the we are living at the distance, but the experience is same. And yeah, and people even it was education and pre-Ramzan assessment and all these factors are very important. I am not saying to anyone. I'm just telling you my own experience that I was very afraid with. I am a person with diabetes and I was diagnosed at the age of 14, and it's been a long time. So I'm not going to tell you the duration, so you will calculate my age. So
I'm not. I won't.
so the and I have catered more than 80,000 patients. So till now, so it's been long time, and the family involvement I feel like is very important, as Dr. Dana said, and it is also very important that uh, we as a healthcare professionals, we have to understand one thing, that no patient is non-compliance. We, I'm so sorry, but we usually tag our patient that they are non-compliant. Actually, they are not compliant. We are incompetent and we are unable to press that button which should be hit to make them educate and empowered. So I feel like that during Ramadan, I'm so impressed with Dr. I don't know the name, how to pronounce that name,
Hi,
Dr.
Sunny.
Ghani
Hi,
Sani.
Sunny. Well, I think we can call her Nina. Is that right?
Yes, Dr. Roy. It's
Oh, thank
easier
I
you.
think it's
for you.
So,
easier,
Dr.
Nina.
Nina, that is very impressive talk, and I must say that many
Agree.
points that there are in the guidelines, but actually practical environment is totally different.
Agree, agree. And also, this is also the question for Professor Dia about the presenting of Dr. Zuhri from Aceh about the people who got the education before Ramadan. It's only 60% something, 60%. And in your opinion, Prof. Dia, how do we can increase this kind of topic? And we need also your comment and your insight, Ms. Kapoor. Please, Prof. Dia.
Yes. Thank you, Dr. Roy. We know that according to study by Dr. Sufri,
Yeah.
actually more than half of the participant already receive education related to diabetes management during Ramadan.
Mm-hmm.
But we know that another study reported that the knowledge of the HCP or healthcare provider is still low. So maybe I strongly recommended that we should conducting regular formal Ramadan management training programs
Mm-hmm.
for healthcare workers and educators. That's my opinion, Dr. Roy. Thank you.
Thank you, Prof. Dia. Miss Kapoor, do you think that you need also, or you have been
I
doing the same in Pakistan?
I totally agree with her. And
Mm-hmm.
yes, the picture is changing from last 4 years that we are changing the way that we don't even ask people that come to for the pre-Ramzan assessment and we need to give the education.
Mm-hmm.
We also decimate this information through mass media, through the different
Yeah.
I would say the mobile carriers, the SMS. So this is how the picture is getting changed now. And now people come by themselves that we need to get assessed for the pre-Ramzan. So what I feel like this is not. Yes, and I totally agree that many healthcare professionals are not trained for it. They need training for it, that how to actually give the education and the monitoring and the assessment and the dose adjustment and etc. But before that, there should be one measure, and that measure is the mass awareness. Because when I know that I need to have education and pre-Ramzan assessment, then I will contact my doctor. If I am not okay, fine, I will go after the Eid. So this is the first step that we need to create awareness, and then we need to provide all these measures and education and assessments. This
Yes,
is
thank you.
definitely my
Yeah.
opinion.
Yeah, I think we full agree of this. Yeah, and this is good that we can share of our experience through this webinar. That's fantastic. It's beautiful. There is a question for Dr. Nina from Muhammad Adrian Shah, pediatric CTS question. At what age or pubertal stage is it medically safe for a child with type 1 diabetes to attempt a full day of fasting? So they are not doing the beduk fasting. Yeah, they call it beduk fasting because it's only from sahur to 12 o'clock. And how do the IDF-DAR risk score change for the pediatric population? And how do we differentiate between fasting-induced lethargy and true hypoglycemia in a clinical setting when the patient is reluctant to monitor their blood glucose? Yeah, I know that a lot of my type 1 diabetes is reluctant to check their blood glucose. So, Dr. Dina, the question is so challenging for you. Please.
Thank you, Dr. Roy. I think this is very interesting and also important questions.
Mhm.
But basically, there's no medically defined safe cutoff age because maybe we take an example that two adolescents, maybe with the same age, probably can have very different risks. Like, for example, the initial diagnosis, when is the first time of diagnosis? Is there any history of previous DKA in the last 3 months? And also about the glycemic control, history of hypoglycemia, and how about the insulin regimen, the level of education, ability to self-monitor the blood glucose could be very different, even though in the same age group. So I think this is very important for us to individually assess the risk based on the personal history of, let's say, the fasting experience before, or maybe any kind of risk related to medical issue like previous hospital admission. I think this is the more important thing rather than, like have the certain cutoff age. Also answering the second question, generally adolescents with type 1 diabetes are considered high risk for fasting. So this is the most important thing that we have to take. There's no specific like scoring really applied to children, adolescents, because they are all considered a high risk group. So we have to be very careful if we are dealing with the children, adolescents. And regarding about the third questions, how we differentiate between fasting-induced lethargy and true hypoglycemia, the problem is we cannot differentiate between it is hypoglycemia or maybe that's some related to fasting because hypoglycemia unawareness is a real problem. When we did diabetes camp last week, we did a quick survey. Like, for example, how many are they experiencing hypoglycemia without symptoms? Like maybe more than 30%, like had hypoglycemia as low as 30, 20 milligram per deciliter without having any symptoms. So this is actually very important. We don't wait for lethargy and hypoglycemia occurs in fasting. So what we need to do is to give like a proper education before Ramadan to make it clear that there is a risk of hypoglycemia even without any symptoms. So this is a very important thing that we can monitor. So adolescents are considered to do the fasting under very strict conditions that they have to be able to monitor their blood glucose. So I think this is one of the main requirement for them to be able to fast. So the one major strict condition is to be able to do the monitoring of blood glucose. If they don't want to do the self monitoring by glucometer, we can advise to use CGM, for example. So it will minimize, the reluctancy and frequent pricking of blood glucose in a day. But again, CGM is not like all available for all population. It's only privileged families that can access CGM. So I think again, education plays a very important role before the fasting, and we have to make it clear to the parents that they are in a high risk group. So we have to make sure that they will be able to monitor the blood glucose during the Ramadan fasting if they want to.
Agree. Thank you. Thank you very much. But education is so important in any aspect of diabetes care. Yeah. There is another question. This is for Prof. Dia, but I think this bounded to what Dr. Farid is presenting. So I give this question to you, Dr. Farid. This is for insulin initiation. Certain patients usually need insulin initiation, but come to us very close before the Ramadan. For example, a new diagnosed type 2 diabetes patient come to outpatient clinic with A1C 13 1 month prior to Ramadan. It is clear that the patient needs minimum one basal insulin or one conformulation insulin. Can we still initiate the insulin administration, or should we postpone the insulin initiation and start it after Ramadan? I think this is a kind of case. I believe that Dr. Farid will happy to answer this. And the second is for patients who have been using 3 prandial doses of insulin, how should we manage their insulin regimen during Ramadan? Should we reduce the injection into 2 injection prior to sahur and iftar only? If the patient inside to eat 3 times additionally pre-bedtime meal, should the third prandial dose be injected? Thank you, Dr. Farid. Yeah, you're
Yeah.
welcome, Prof.
Thank
Dia.
you, Dr.
I will
Roy.
let Dr. Farid. Yeah, please.
Yeah, the very good questions. And I think Dr. Roy and also later Professor Dia can add on my answers. First, related with the insulins. Yeah, it is if you have patients that are indicated to have or to get insulins, like I think you mentioned the A1C is 13, and I assume that maybe it's these patients also have those classical symptoms of diabetes. So it's better to initiate basal insulin to these patients and also combine either with oral antidiabetes, or if you want to can also combine with other prandial insulins. So if these patients comes, ideally these patients would be come to you like 2 months or 3 months before Ramadan. That would be really ideal. But if these patients come to our practice, let's say 2 weeks or 1 month before Ramadan, then I think it's better for these patients not to advise not to fast. That's the first. That's my recommendation, because it will be too risky for these patients to perform or to practice Ramadan fasting while he or she still not being well controlled for their glycemic control. So it's so not because that this patient will have or will get insulin, but his or her blood glucose is still not well controlled. It's the A1C is 13, and if you look at the guideline for the IDF, for the A1C that it's above, I forgot the cutoff. It's contribute to really high, quite high score, and it's advised not to fast. So if you can assure these patients not to fast, then you have a lot of time to adjust the insulin and also the other medications. But in a lot of cases, maybe you will have the patients that insist to fast. Then you need to titrate the insulin closely and more aggressive. So you can ask the patients to adjust the insulin and also the I think like the basal insulin you can adjust every 3 days along together with also the oral medications, and you can already observe the results within 1 week or 2 weeks whether the blood glucose will be controlled or not. And then if really insist to having fasting, then you ask them after you have a good control of the blood glucose, then you ask them to practice like in I think we have like Monday, Thursday fasting or Dawood fasting. Then that's the way you practice adjusting the insulin and also the oral anti-diabetes medications. That the first, maybe later, I hope, I'm sure that Dr. Roy and Professor Dia can add to this question. And to the second questions is that whether if the patients have 3 times prandial insulin, yeah, you should reduce it to only twice daily prandial insulin before sahur and before breakfasting. So you give the morning insulin to become as a sahur, and if it's you usually we reduce the amount of the insulin before the sahur, especially if she or he or the patient's intake is less than usual. And for the insulin dosage, in the evening, you can just use it as the insulin dosage during the breakfasting, and you omit the insulin in the midday because the patient do not have any intake, and you ask about whether if they have small meals during the night, like before bedtime, do you need to add more insulin? I think this is mostly not, but if you have like type 1 diabetes, that can be considered. But the distance between two each prandial insulin, it will be too close. If the it's more than 4 hours, it can be considered like a small additions, and you just perform the carbohydrate counting for the like snack before bedtime, then you can add more prandial, like very short, like the rapid acting insulin. Yeah, I think that's my answer. Maybe Dr. Roy, Prof. Dia, and also Dr. Nina can add on this answer. Thank you. Still mute, Dr. Roy. Sorry.
I totally agree, and uh, we all agree about that, and we need some education also. Is that so, Prof. Dia here? Uh, and Miss Arum should leave, but I have one question on behalf.
Yeah.
You would like to give your opinion, Ms. Kapoor, and also I need some, some insight from other participant or other speaker uh, in this webinar. The question is coming from on behalf of Anita and also from me actually, because we discuss it a lot about the child the type 1 diabetes in Saudi Arabia can be freed of fasting by doing the vidya. Uh, and this is also something that is, it can be a good juice or it can be a bad juice. Or do you have any opinion about it? Firstly, Ms. Gavur.
Well, I would say that is all about your belief, because right now they also allow us to do the Hajj and Umrah without mahram. So this is all about belief, because I am sure that Allah will ask me for my deeds. So I would not say that it is fine, but yeah, in some circumstances, you can have I would say we have the fatwa from religious scholars. So, for example, the one of the patient came to me and said to me that I am wearing the CGM. I am wearing the CGM right now, and CGM, and I am feeling like that I'm not having ablution, so my rosa will be damaged. So I went, and I can't ask them that off the CGM. So I went to made a request to the biggest institute of Islamic in Pakistan, and they gave the fatwa that you can do the wuzu with CGM sensor, and that will be fine. So sometimes I feel like, yes, I would say it is controversial. It should be on your belief. I have yesterday I have a very, I would say, big debate with a patient when I was telling them that you can have insulin during fasting. That is not the problem. And I was even explaining them that your fasting will break when something went to the gut. And even then they were not convinced. And then when something is like that religious thing or religion get involved, that we always have should away. So I told them that okay, go had a you will have a date and go for the namaz, go for the injection and go for the namaz prayers and come back and then do it, so it will take the time. So,
Mhm.
coming back to you, the point that it is all about the belief. I would not say that, because I am the person for the responsible for my deeds, for my sins. So, if I believe that it is okay, it is okay, and if I don't, then it is not.
Beautiful, beautiful insight, Gafur. Anybody want to make some additional for this issue?
Can I
I think
go?
it, yeah, please.
Yeah, yes, yeah, because I mean, talking about what Arun said before, it's based on your belief and also based on your confidence on doing fasting. For example, as a type 1, and I'm using a CGM and I'm using a hybrid loop pump, which enables me to monitor, to manage my diabetes more easily. So that's why I'm confident on doing my Ramadan fasting. So it's back on the belief and also on preparation on how you will do your Ramadan fasting. The preparation itself means a lot.
Okay, this is the voice of my very best friend, Anita Sabdi. Thank you, Anita. And you know that we have already been talking 2 hours at 20 minutes, and I believe that this is such a very good time to collaborate, Ms. Kafuria. This is very nice, and I hope that we can also make some joining webinar program with you and also with your friends from Pakistan. We have so much in common, especially in this kind of field. So I would like to close this meeting if there is no more additional insight from both of you. But I have to make some resume for this. That from Dr. Farid, the patient need to be very uh, we need to do some more subject for doing the more data for this kind of issue concerning the continuous glucose monitoring report about the result that is still questionable. And number second is from Dr. Sarah, patient with sulfonylurea and need to expand the monitor. Yeah, because this is a very important thing. Then also we need to do some special or particular medication of sulfonylurea for this special moment of Ramadan.